Uh, let's start from the beginning. Where did you grow up? How was your childhood?
Yeah, so I was born and brought up in Mumbai.
Okay.
I lived in Ville Parle most of my childhood and my teenage years. I come from a simple Maharashtrian educated family background.
Non-medical background.
Non-medico, totally non-medico background.
What did your parents do?
My father is a retired manager from Hindustan Unilever Limited, and my mother was an officer in Reserve Bank of India.
Oh, nice.
Yeah.
So Ville Parle must be very quiet and cozy during. Abhi bhi when I go there, it still sounds not like Bombay is. It's a little cozy as compared to Bandra.
At that time, it used to be compared with Pune.
Right.
And I think Pune is a bustling city, and so is Ville Parle now.
Nice. So, why medicine? What attracted you towards doing MBBS then?
To be honest, I was not very good at mathematics.
I suppose.
And then in those days, there were only two fields which we used to think about with our tunnel vision. And doctor hona manje, the parents used to be very proud of doctor children. So I don't think I put much thought to it. I just decided in school itself that I would like to become a doctor.
Oh, nice. But then after doing MBBS, where did surgery come into the picture? What was the attraction and the love that drew you towards surgery then?
That was a very, very early decision in second year MBBS itself.
Oh, nice.
Yeah, when I did my first surgical posting,
right,
I thought this is what I want to do all my life, nothing else.
But then Sion MBBS then at Nair Hospital.
Yeah.
What was the environment like then?
Sion was just like a school.
Okay.
Very strict, very disciplined. All our professors were very meticulous, disciplined. Actually, we had a classroom where the professor used to, the physiology professor, Dr. Dabolkar, he had studied our I-cards. And when we used to enter college, he used to call us by our names. So that was very surprising. And I went to Nair because I got married in internship and my husband was studying in Nair.
Oh.
So, so I mean, that just came as an automatic choice.
Right. But, there is always a mentor that teaches you surgery for the first time and that mentor stays with you entire life.
Yeah.
Who was that mentor for you?
I worked with Dr. Shiratti, who was a GI surgeon in Nair. I was registered with Dr. Hardikar, who was a very good surgeon. And then our lecturers at that time, Dr. Damodaran, Ashok Damodaran, he was a very good surgeon. And in Mumbai, the thing is, they used to literally scrub with us, assist us, all our surgeries, including emergency work. So there was Dr. Rajiv Joshi, there was Dr. Madhuri Gore. Madam was my inspiration actually. She was one of the most elegant lady surgeons at that time. She was an associate professor. Now she is a very senior, retired and a very respected surgeon in Mumbai. Then Dr. Deshmukh, Snehalata Deshmukh, who later became the Vice Chancellor of Mumbai University. Amazing. She was Dean of Sion Hospital at that time, a very renowned pediatric surgeon. So these two ladies actually literally, they prompted me, they motivated me to take up surgery.
Are you still in touch with them?
I am very much in touch with Dr. Gore.
Okay.
Yeah.
Very nice. Yeah. So then walk me through the FRCS thing.
Yeah. So at that time, it was like to go to UK. I mean, because my husband went ahead to UK and after MS I went there. The system was to pass part 1 examination. So we had to study basic sciences, which was quite a difficult thing, a tough task after studying for MS. Just gave the exam and went to UK and started again with anatomy and physiology, everything. And then I passed my part 1. And then the second part, that was part 2 FRCS, was clinical. So it was theory and ward rounds and vivas. So theory was again going back to the basics of general surgery. And I'm sure you know that the British are, very much into basics.
Yeah.
So the theory was all about basics of general surgery. And that was also, again, it used to be an MCQ exam along with some theory questions as well. Then we had vivas. And the third round was a grand round. So it was not only about testing your clinical knowledge, it was about even interacting with patients, bedside manners. Yeah. So all those things were extremely important. And I passed the exam at first attempt, so that was a big thing.
You know, there's a very stark difference when you're doing internship or you're doing your residency in a high volume government hospital or a charitable center. Your behavior with patients is in a very rushed manner.
Absolutely.
And then there is a little bit harshness that comes along with it. But and a lot of doctors carry that into practice later on, then they have to unlearn and relearn everything. It doesn't happen in UK, it doesn't happen in US. The bedside manners are very respectable.
Exactly.
So I think it's a very different thing altogether. So what did you learn over there? What was your FRCS like? You worked with multiple hospitals.
Yeah.
What all did you gain? How is that system different from Indian healthcare system? What did you notice?
So I got into the SHO rotation, and that included working in the A&E, the accidents and emergency units, and then into general surgery units. So I worked mainly with breast and GI units over there, and A&E was a totally different experience because first of all, in A&E you deal with patients who come rowdy, drunk sometimes.
Right.
Yeah. As surgeons in India, during our surgical training, we are just focused on our part of work. So we are not into managing the patient as a whole. At that time, the system was very different. I'm sure now it must be totally different in the UK as well. But fast tracking was very, very important at that time. Triage was very, very important.
Yeah.
The assessment of patient from the patient as a whole perspective, and triaging them, and whoever needed surgery would immediately go into the emergency setup.
Right.
So what you said initially, I have experienced it firsthand, because when I came back to Nagpur, so my journey was Mumbai to UK and then to Nagpur.
Right.
So Nagpur, when I came here, it was a huge cultural shock for me, and the way the patients are, talked to. So that was something which really impacted me. कारण नागपूरमध्ये आल्यावर वॉर्डमध्ये असे 10 पेशंट पडले असताना काय बाबाजी काय होत आहे so all these, even the terminology was totally different for me.
Absolutely.
Yeah, so it took quite a bit of time for me to get used to it, but I think I carried my basic my personality as it is, and I was comfortable.
So you were doing GI and breast in UK as well.
Yes.
And then where did this breast conservation surgery, when did this come about?
Yeah. So I worked with in Countess of Chester Hospital.
Right.
And there was a focused breast unit over there.
Which year was this?
This was in 1998.
Okay.
Yeah. 97, 98.
Right.
So at that time, in Nair Hospital, we didn't have a breast unit. They are just coming up now, after 30, 35 years.
Really?
Yes. But in those days, it used to be like one consultant who would look after breast. And then the plastic surgeon used to do the reconstruction job, which at that time was mainly implant based. So now everything has changed.
Also, what has changed?
Yeah, it has advanced into a field of its own, which is breast oncoplasty. So, there are three levels of oncoplasty, if I could just touch upon them in brief.
Absolutely.
Yeah. So, as we all know, any cancer has stages, right? So, stage 1 and stage 2 are considered curable stages. And त्याच्यानंतर stage 3, stage 4, you have to do something to downstage the cancer and then treat it operatively. So in the initial stages with a smaller lesion, what we do is a level 1 oncoplasty. So basically the idea is onco and plasty. So we have to keep oncological safety in mind, and at the same time giving good cosmetic outcome to the patient. So with a small lump, it is a level 1. That means whenever we remove the lump, the lesion, with a good oncologically safe margin, we need to create good cosmetic outcome in terms of maintaining the shape of the breast. This we do level 1 when the defect is less than 20% of the breast volume. And we need to see to it that there is not much asymmetry compared to the other breast. So there are certain procedures where we mobilize the breast parenchyma itself and fill in the gap.
Okay. Fill with what?
Fill with breast tissue itself.
Okay.
So we mobilize the breast parenchyma because, as you know, the breast is a very fatty structure, fat along with glands. And there are various different criteria in which we decide which patient needs what. If there is a larger defect between 20 to 50%, then we do something which is known as a level 2 oncoplasty. So that includes a variety of procedures, but if we talk about autologous procedures which are not implant based, then there is something like perforator based flaps, or fat skin and subcutaneous flaps, or myocutaneous flaps. So those are mobilized from the tissue, the fatty tissue in the axilla, or the infraaxillary tissue, where we tend to have a lot of fat in that area, in the lateral chest wall. So in most patients we use that fat. Then the viability of that flap is very important. So we find out the vascularity of the flap which we mobilize by doing a Doppler test, a handheld Doppler, and then we base the flaps accordingly.
Okay.
So the focus has to be on giving good cosmetic outcome to the patient.
Right. But this is usually before the metastasis has happened.
Yes.
Only then you can do this, है ना?
Now, with advances in medical oncology, there are so many newer chemotherapeutic agents, immunotherapeutic agents, which are very targeted, and they cause downstaging of that tumor very easily. So we can do a breast conservation even in patients who have a higher stage after neoadjuvant treatment. So that
really?
Yes, it is very much possible, and it is a big advantage because nowadays we are seeing very young patients.
Yeah, definitely.
So a mastectomy is definitely not a first choice for a young patient.
But this oncoplastic procedures can also be done in a fibroadenoma?
They can be done if it is a large fibroadenoma.
Yeah, the benign ones, no?
Yeah, the benign ones. So that is an extension of the indication of oncoplasty.
Okay.
Most of the fibroadenomas don't need any oncoplastic procedure.
Right.
Yeah.
Nice. So you were doing wonderful work, Countess of Chester, then the Royal Liverpool, the Wirral NHS Trust. Why did you come back? I mean, this was the best of the best place you could be at, early 2000s probably. Why?
We had always decided to come back.
Really?
Yeah, we never wanted to stay, outside India. At the same time, gathering experience was extremely important. And it's always better to get all the experience, the, foreign experience you can get before you actually come and settle.
True.
Once you are in one place, then it's not possible.
Very difficult to move.
It's not advisable to move as well.
Right.
Then even 9/11 happened. So that was again a shift, because there was a definite change in attitude towards brown colored people after that. And it was always decided my daughter should be starting school in India itself. So that was something we had decided before.
So I think 2002 you came back?
Yes, came back in 2002.
And that too you came to Nagpur.
Yeah.
And for a Mumbaikar, this was a cultural, linguistic, surgical, medical shock. I think these are the correct words I've tried to use.
It was a huge transition.
Yeah.
But my grandparents on my father's side were in Nagpur.
Okay.
So, I had been visiting Nagpur in vacations as a child.
So, but as a doctor, when you've come back, what was Nagpur like then surgically? How ill-equipped was Nagpur then?
It was quite behind Mumbai, I would say,
obviously.
at that time. Yeah. And I joined IGMC. It was IGMC that time. So as a lecturer, as a locum lecturer. And that was, as I said, in the wards, it was a shock. Even in the OTs, the operation theatres were totally different. I remember the emergency OT did not have a cautery. So I had never ever operated without a cautery. And, doing all kinds of trauma and stabs and laparotomies there. There was no custom of even changing clothes to enter the OT at that time.
Really?
Yeah. So it's just, wear a gown on top of it and start. So everything was different. And then I was there for a couple of years. So laparoscopic, the laparoscopic system was just being introduced in IGMC at that time.
You were also doing locums in UK as well, no?
A few locums, because I had to take a break when my daughter was born.
Right.
She was born very, very premature.
Right.
And I had to be at home with her.
Right.
So after that, just before coming, I did. And I used to read a lot of surgery before I came back.
You worked at IGMC, you worked at Mure Memorial as well.
Yes, so that was after. I used to enjoy teaching. I used to love teaching.
Oh, okay.
So after that 2-year stint, it was not a permanent job. And then I did continue as a reader in homeopathy college for a few years. Because
what is a reader?
A reader is something between an associate professor and a lecturer.
Okay.
So that was a visiting thing, but I used to enjoy teaching, and it's nice because, all my students, even from IGGMC in those days and homeopathy college, they are practicing nowadays, and I keep, I meet them quite frequently, somewhere. So it's a very gratifying experience. After that, I joined Mure Memorial, which was another very nice experience. It was a very cozy place to work in. Very gentle, compassionate people. Then I joined Lata Mangeshkar Hospital. I mean, I have had all these visiting things, and I'm still attached to Orange City as well.
You're still attached?
Yes, I'm still attached.
Then when did you decide to start Mahajan Ortho and Surgical Care?
That we had invested money while we were in the UK. So the hospital, we started in 2003.
Right.
It took a year of completion after we came here. And my husband had started working there, and I was working, I was doing evening OPDs and all. And once in 2004, I was completely into private practice.
How does a 2-surgeon household look like?
That is a very good question, because I don't know how to really express that. It happens.
Think about it.
Yeah. The thing is, most of it, now we have an empty nest. Previously, it was like I used to adjust my schedule according to my daughter's school and classes and everything. And I'm proud to say that I still cook. I have never stopped cooking at home, morning and evening. I enjoy cooking as well. So it was not like, left to the cook or the maids or anybody. I am a very hands-on, have been a very hands-on mother, and I'm dedicated to my kitchen. And I'm quite particular about it still. So it used to be managing different fronts. It used to be managing my professional front, my daughter's school schedules, and later 11th and 12th standard, her classes, tuitions and everything. So in those days, I used to adjust all my work timings as per her schedule and the home schedule. Now that she's been out of home since the past 8 years, I actually, started not having any restrictions as far as timings are concerned. Right. So I went full throttle mainly after she went out of the house.
What is she studying?
She did her engineering in geoinformatics in Dehradun.
Okay. Right.
And then she has done her MBA in sustainability management.
Oh, nice.
Yeah. And my husband starts his work at 4 a.m.
Right.
And so I don't get the OT till he finishes. So that
Still
is only
today
after. Yes. So 10:30, 11. So my operating schedule starts after that. And my OPDs and everything. So since you're asking about the home front, we hardly meet each other except for a few, exchange of conversation in the OPD in the daytime.
I've been born and brought up in a 2-doctor household.
Yes. Right.
We are a very nuclear family.
Yeah.
My grandfather passed away, and it was only Aji. Before mobiles were invented, I remember you could put an alarm on the BSNL landline.
Yes, we could do that.
And my father used to put an alarm for 3:30 a.m. And by 4:15, my mom and dad used to be out of the house.
Oh gosh.
And I can totally relate to sir leaving out a house at 4 a.m. And by and large, I have seen doctors च्या घरी पसारा असतोच, because both of us all of us are working. So when a non-medico comes, it's very different for them to see what is happening. it's a chaos, controlled chaos. So how do you both both of you meet each other mostly during interchanging OTs?
Not even that, a little bit of, conversation between the OPDs maybe.
Right.
But since he starts that early, he is home in the evenings, usually before me.
Okay.
Yeah, so we have dinner together and then we sit and watch TV for an hour or so.
Lovely.
Yeah. And Sundays.
What was the initial struggle like for the both of you?
Yeah, initial struggle in terms of we were totally new to Nagpur.
Exactly.
Because he is also studied in Mumbai.
Exactly.
And when we came at that time, the culture was more like batchmates. The cohesiveness. I'm sure it still continues, and it is bound to happen wherever we go. But we always, we just believed in ourselves. We never went out of the way to, promote ourselves or anything like that. And I'm really happy and grateful that it just worked, slow and steady. Yeah.
Let's talk about surgery. When I take up a patient on table, mostly ophthalmic surgeries are topical anesthesia. Yeah. So it's not very psychologically scary for the patient to be there, because it's a very light-hearted thing that's going on. But when you are about to give a GI surgery or a breast surgery, how do you counsel the patient psychologically?
That is extremely important, right, especially in cases of cancer. Yeah, so I'll mainly talk about that because other surgeries patients are at least prepared. Nowadays they are on the internet, so they know what is what, they know the procedures, they study everything and come. But all said and done, any patient would be scared, and I am sure I would be scared to undergo an eye surgery as well. But so counseling takes a lot of time, especially with women. And to break the diagnosis of cancer, what I usually do is I see to it that I talk to the relatives first, as far as how much the patient already knows. And most patients are aware.
Nowadays they are very aware.
Yeah, they are always aware. Even if it is a lady coming from a rural area, everybody knows what cancer is. Yeah.
Yes.
And it's not possible to hide or conceal facts from them. Because mentally, that is the only thing they are worried about.
Right.
The only difference is presentation. Somebody coming from a rural background is still, worried and postponing and not going to a doctor. It can happen in cities as well, and in very, educated families as well. People don't tell so easily. But breaking the news is one thing, and we have to do it gently. So usually I ask the relatives how much the patient herself knows. And then I usually tell them that, you talk to her in your own way because you are family and you can explain it better. And once you have at least conditioned, then, I will talk to them in my way.
Oh, so you talk to the relative first, then you send them home, and then the patient
I don't
comes
send
to
them
you.
home,
Okay.
but usually I send them to, have a BP check or something like that with the nurse outside.
Okay.
So that is when I just gauge what the family thinks about it. And usually, the relatives try to tell me, unko kuch nahi batana, humne kuch bataya nahi hai. But then I tell them that I have to talk to the patient and let me talk in my own way. So what any patient needs is hope, optimism, right? So if we are able to convince the patient that everything is under control,
होऊन
जाईल.
Exactly.
म्हणजे इतकं तुम्ही seriously घेऊ नका. Of course, it is something which is very challenging. But patients recover, go home, and they lead a happy and normal life.
True.
So it is important to reassure the patients that the outcome is going to be good.
So let's talk about a very important discussion. We are in an era of hyper-specialization, and the generalists are dying out.
Right.
So every organ has a specialist doctor. Do you think there is still a room for a generalist?
That is a very important topic for me and quite a favorite topic because I've even given a few presentations at conferences and I've even written about it. So I think that what is most important is basic surgery. You cannot just focus only on one organ unless and until you have a knowledge of tissues, including tissue handling. Nowadays, resident doctors jump onto laparoscopic surgery, which has no direct tactile feedback, and nowadays they are exposed to robotic surgery without actually having. So, I don't say that they are not taught about open surgery at all, but I think the journey we went through, our generations, who progressed from open surgery to minimally invasive techniques, was important because the feel of tissues is extremely important.
True.
Yeah, so in laparoscopic surgery, we do get a feel of resistance, of give, and we know by intuition how the tissues feel. So I think it is very important. For a person like me who wants to put her hands everywhere, it is not possible to focus on one particular thing because basically I love surgery as a whole. And I enjoy doing all kinds of surgery.
Right.
So I think it's mainly about a person's outlook. And nowadays, of course, I think it is the need of the day to focus on, hyper-specialization. because just being a general surgeon in the future may be difficult. But a time may come when there is again a need for general surgeons.
Two of my friends, very good laparoscopic surgeons, they swear by one thing ki kabhi na wo lap is not working, you understand, and then you have to convert to open.
Yes.
And every time he's like, I have had 2 incidents जब मेरे को switch करना पड़ा है, but I did not wait for my ego to come into the place. I called a senior surgeon. ते आले त्यांनी convert केलं, मस्त close केलं. We ended up without any complications. Yes. But then I asked him कि why couldn't you convert? He's like, यार मेरे को ना उतना अच्छे से, I'm not very confident.
Yes.
So you should, I totally agree कि you should know everything.
You should know everything.
Absolutely.
And I have heard of this too, कि people have to call somebody senior because open surgery मध्ये confidence इतना नसतो. And we need it. It's basically the time and the decision making, which is very important. One cannot go on trying minimally invasive and waste anesthesia time and all. That decision making is most important.
True.
If we realize that we cannot make progress because of whatever condition it may be patient related challenges, and it happens. So that decision making is very important. Ultimately, we are just concerned about the outcome.
Yes. Outcome has to be good.
Yeah, the patient has to be healthy and happy.
So, you do breast oncosurgery, you do GI, hernia, and everything, solid organs and all. What superpower do you get because you can operate across the breadth that a super specialist does not have?
I think one thing is experience. Yeah. I usually think about the surgeries which I'm going to do during the day. And I believe, this is being a little bit philosophical, but I firmly believe in gratitude. So I begin my morning with gratitude towards my skills and my experience, and of course and gratitude towards the patient who is placing their faith in me entirely. And usually I think through the procedure, even if it may be a laparoscopic cholecystectomy also, I usually think, I just close my eyes and think about what the sonography picture looked like, so what kind of challenges I might have, or the stature of the patient. So any procedure I usually think it through in the morning. So it's a basic power. It's not a superpower, but it's a basic thought process. So if there is any kind of difficulty, I am mentally prepared for that.
But I have noticed this about myself very probably 3-4 years before I've realized that when you are scrubbing in, you are mentally doing steps in your head already.
Yeah.
And I've realized after so many years, most surgery happens at a spinal level. At least I don't know, it happens with me. The more I try to control it, kaitari gadbad hote. The more I let myself go, and our hands are they're trained to move in a certain way. So you should not push it. So the more you do it at spinal level, the more better outcomes you get.
Most of the things are done in auto mode because of our experience.
Exactly.
Right. But sometimes we think that maybe this individual is now recently I operated on 2 patients for hernias. So the first one, a very short-statured individual. So short-statured and very thin-built. So what happens is our instruments are very long. So logistics becomes a problem. Then the next patient had some spinal deformity and all those things. And there is no point in, putting in a scope in such a small statured patient with a spinal deformity. Might as well do it open and do it quickly under regional anesthesia. So, of course, it is important to think, but when the procedure starts, you go into auto mode.
So, but generalists are in PHCs, rural hospitals. There is always a generalist. You will never, I think, super specialists you will find in urban centers, and generals you will usually find. That's
that trend is changing now.
That's not a very right classification I'm trying to build, but a patient in the rural, a doctor in the rural area, he needs to be a generalist.
Yes, of course.
Very true, hai na?
And not just a general surgeon.
Yeah, everything.
Everything.
Very true. So, what do you think with this hyper-specialization? What are we losing?
We are losing a lot, many things.
Like?
Yeah, like basically, I have heard, because I am not into any medical college teaching right now, But I have heard that the students are not interested in studying or being taught. You may be knowing better.
No.
That is what I'm told, even by medical college teachers, that children don't attend lectures. They are only focused on preparing for the entrance exams. Residents are just busy or more keen on preparing for the super specialty exams. So they are focusing on their final goal. And basic things like what to do in an emergency, or if you're doing one thing and something else suddenly comes up, how to deal with it. All those things are very important. I mean, even a knowledge of other systems. We have to have knowledge of medicine. We have to have knowledge of anatomy. All those things are anatomy of the whole body, not just the part we are talking about. So I think we are losing out quite a lot.
My friend is an ophthalmologist. Her husband is an intensivist.
Okay.
So once we were having dinner and we were comparing both the fields. So he's like, "Ha ECG वाचून दाखवा तुम्ही लोक." And we were like, we realized we've forgotten how to read an ECG. याद ही नहीं है because, and it was a very funny incident. If you were given the choice to curate the general surgery curriculum, what would you keep? What would you change?
I'm not aware of exactly the theoretical curriculum right now, but I feel that our time was better. Because we used to deal with all kinds of all organ systems of the body. And then in those days, we used to have in Nair Hospital, we used to have a 2-month posting in burns. And we were exposed to ENT and ophthalmology. Of course, we did not do there, or maybe we did not even attend much. But that burns posting also helped a lot in terms of, even a lot of nutrition about knowledge about nutrition and how patients were cared for, burns patients. So nowadays, although I don't do burns, I'm still, I have a sort of empathy or compassion for those patients because of the way we used to do dressings and skin graftings at that time. Then we also were exposed to a few months or a few weeks, 6 weeks, I think, in urology, neurosurgery, cardiac surgery, plastic surgery. So we were exposed to super specialities as well. While doing our general surgery, and then we had an option to pick and choose whether we wanted to do our MCH or we wanted to remain general surgeons. So I think some things need to go back in time.
So we have had Dr. Jayadeshmukh over here,
yes,
and we have had Dr. Anand Kate over here.
Right.
Both of them made a point that we are losing the generalist doctor.
Yeah.
There should be, in terms of their field, medicine,
yes,
there should be a go between the family and the super specialist doctors. The generalists need to tell them that he's like an all connecting dots wala kind of a hub and spoke model.
Yeah.
We are losing that. So the generalist needs to make a comeback.
Yeah. I have heard both the interviews.
Oh, thank you.
Dr. Jayadeshmukh comes from Sion Hospital again.
Yeah.
So we usually have had these conversations for many, many times.
Oh, nice.
Yeah.
So let's talk about breast oncoplasty. Abhi अच्छे से. We'll switch to Marathi for the people can understand. What happens in the breast जेव्हा cancer develop होतो?
कॅन्सर डेव्हलप कधी होतो याचा म्हणजे खूप पेशंट्स विचारतात की ही गाठ कधीपासून असेल.
बरोबर.
तर युजली पेशंट्सना माहिती असतं की काहीतरी चेंज झालेलं आहे. ते दुर्लक्ष करतात कारण त्याच्यात दुखणं नसतं. दुखलं नाही, काहीच त्रास नाही झाला म्हणून आम्ही दाखवलं नाही.
बरोबर.
आणि मग एखाद वेळेला काहीतरी होतं. इन व्हेरी ॲडव्हान्स्ड केसेस कधी कधी एकदम फंगेट होऊन बाहेर पण येतं. तर असे पण पेशंट्स असतात. नंतर खूप पेशंट्स बाहेर म्हणजे क्वॅक्सकडे जातात अजूनही, आणि मग खूप वेळ त्याच्यात फुकट गेलेला असतो. तोपर्यंत पेशंट्स एकदम ॲडव्हान्स्ड स्टेजमध्ये येतात. तर अशा लोकांचं खूप वाईट वाटतं की ही गोष्ट लवकर आली असते तर किती बरं झालं असतं पेशंटच्या दृष्टीने. तर ती एक गोष्ट आहे. आणि सिम्पटम्स तर आपल्याला माहितीच असतात. आणि जनरली आजकाल सोशल मीडियावर आणि सगळीकडे इतकं सगळं सांगितलं जातं, पण ते प्रॉपर नॉलेज नसतं दिलेलं. त्याच्याबद्दल प्रॉपर माहिती नसते. खूपच शॅलो. प्रत्येकजण आपापल्या मताप्रमाणे काहीही बोलतं. आणि लोकांची अशी टेंडन्सी असते की डॉक्टर्सचं ऐकण्यापेक्षा ते बाकी लोकांचं ऐकतात. तर मी प्रत्येक पेशंटला हे सांगते की तुम्ही ते नुसतंच सोशल मीडियावर बघू नका. स्वतःची तपासणी करा. ब्रेस्ट सेल्फ एक्झामिनेशनसारखं दुसरं काहीच नाही आहे. आणि काहीही वाटलं तर लवकरात लवकर तुमच्या घरातल्या मेंबर्सना सांगा, तरच तो उपचार योग्य पद्धतीने होऊ शकतो. आणि आजकाल ऑपरेशन्स असं नाही की काही गाठ दिसली तर लगेच ऑपरेशनच करावं लागतं, किंवा आधी त्या आजाराचं निदान तर व्हायला पाहिजे की नक्की काय आहे, ते कुठल्या स्टेजला आहे. तर हे मला वाटतं सामान्य माणसांना खूपच शिकवायची गरज आहे. कितीही याबद्दल बोललं तरी ते कमी आहे.
बरोबर. बट फॉर अ ले पर्सन की एक ब्रेस्ट कॅन्सर झाला तर काय होतं आहे, व्हॉट एम आय प्रोसेस काय असणार आहे, मला ॲज अ फिमेल मला काय फील होणार आहे ते प्रोग्रेशन.
तर ते एकदा डायग्नोसिस करणं इम्पॉर्टंट असतं. खूप लोकांना असं वाटतं की किती तपासण्या करतायत आणि अजून काही करतच नाही आहे ट्रीटमेंट, किंवा काही औषधच सुरू केलं नाही. पण हे सांगावं लागतं एकतर की ही सगळी प्रोसेस आहे, हे सगळं झाल्याशिवाय आम्ही ट्रीटमेंट सुरू करू शकत नाही, कारण तुमचं डायग्नोसिस होणं सगळ्यात महत्त्वाचं आहे. त्याच्यानंतर त्यांना समजावून सांगावं लागतं की पुढची काय प्रोसेस असणार आहे. तर जेव्हा छोटी गाठ असते अर्ली स्टेजमध्ये, तेव्हा सगळ्यात आधी ऑपरेशन करावं लागतं. म्हणजे जो आजार आहे तो शरीरापासून दूर करावा लागतो. आणि त्याच्या पुढची जी प्रोसेस असते, म्हणजे किमोथेरपी किंवा रेडिएशन किंवा जे काही पुढे आवश्यक असेल ती प्रोसेस, तर ती पुढच्या रिपोर्ट्सवर अवलंबून आहे. आणि त्याचा उद्देश तो कॅन्सर परत होऊ नये हा आहे. तर तसं तर सगळ्यांना असं आपण समजावून सांगितलं तर कळतं पेशंट्सना की जे होतं ते आता निघालं आहे. सगळ्यात जास्ती भीती लोकांना किमोथेरपीची असते, कारण त्याच्याचबद्दल सगळं ऐकलेलं असतं, केस जातात, खूप त्रास होतो वगैरे वगैरे. आता बऱ्यापैकी म्हणजे खूप ॲडव्हान्स्ड टार्गेटेड ट्रीटमेंटमुळे साईड इफेक्ट्स खूप कमी झालेले आहेत. हॉर्मोन थेरपी, कधी कधी किमोथेरपी, ते डेंजरस इंजेक्शन्स लागतही नाही, टॉक्सिक सगळी ट्रीटमेंट. पण ते आपण आधी सांगू शकत नाही, ते बऱ्याच गोष्टींवरती अवलंबून असतं.
ब्रेस्ट कॅन्सर आपण डायग्नोज कसा करायचा, व्हॉट आर द डायग्नोस्टिक मेथड्स, सगळ्यांना FNAC करायची गरज असणार का, और इज देअर एनी अदर वे टू एस्टॅब्लिश अ डायग्नोसिस?
जसं मी सांगितलं त्याप्रमाणे सेल्फ एक्झामिनेशन, स्वतःची तपासणी करणं दर 15 दिवसांनी आंघोळ करताना. म्हणजे डॉक्टर अर्थात सांगतात, किंवा इवन आजकाल आशा वर्कर्सना पण हे एज्युकेशन दिलेलं आहे की कसं एक्झामिन करायचं स्वतःला. आणि काहीही लागलं तर डॉक्टरकडे दाखवायचं म्हणजे इमिजिएटली. त्याच्यानंतर FNAC आजकाल आपण त्याच्यावर डिपेंड नाही करत. हां, मॅमोग्राफी केली जाते. आणि जिथे कॅम्प्स घेतले जातात तिथे स्क्रीनिंग मॅमोग्राफी, समजा आउटरीचमध्ये आपण कॅम्प्स घेतले तर आपण त्यांना शहरात बोलावतो की या ठिकाणी ही मॅमोग्राफी होते, तर ते तुम्ही करून घ्या आणि रिपोर्ट दाखवा. तर मॅमोग्राफीमध्ये आपल्याला कल्पना येते की हे साधं आहे की कॅन्सरस आहे. त्याच्यानंतर आजकाल आपण सोनोग्राफी गायडेड कोर बायोप्सी, दॅट इज द गोल्ड स्टँडर्ड. FNAC वॉज ॲक्सेप्टेड प्रिव्हियसली, बट नावडेज इट इज नॉट ॲक्सेप्टेड. राईट. पण मागच्या एक 7-8 वर्षांपासून और 10 वर्षांपासून म्हणा, बायोप्सी इज द नीड. आणि त्याच्यातच आपण जे ट्युमर मार्कर्स, आपले रिसेप्टर स्टडीज केले जातात, त्याप्रमाणे पेशंटला फ्युचर एक प्लॅन ऑफ ॲक्शन पण आपण सांगू शकतो. तर ही प्रक्रिया आहे. आणि त्याच्यानंतर मग ऑपरेशन कुठल्या प्रकाराचं करायचं, म्हणजे अजूनही पेशंट्स म्हणतात की आम्हाला मॅस्टेक्टमी पाहिजे, तर मग आपण मॅस्टेक्टमी करतो. मॅस्टेक्टमी इज नॉट आउट. देर आर सर्टन इंडिकेशन्स वेअर मॅस्टेक्टमी इज नीडेड, पण हा चॉईस अल्टिमेटली पेशंटचा आहे. एका पर्टिक्युलर वयानंतर पेशंट्स म्हणतात की नाही, आम्हाला ते वाचवून मग पुढे काही नाही, आम्हाला टेन्शन नको आहे, तर पूर्ण काढायचं आहे. आय थिंक अजूनही 75% पेशंट्स हेच म्हणतात, मॅस्टेक्टमी.
सो ॲज अ सर्जन तुम्ही डिसाईड कसं करता की लंपेक्टॉमी वर्सेस मॅस्टेक्टॉमी, तो डिसिजन मॅट्रिक्स असतो ना काहीतरी, व्हॉट इज इट?
त्याचा एक पूर्ण फ्लोचार्ट असतो. आणि म्हणजे व्हेरियस फॅक्टर्स आर इन्व्हॉल्व्ड. एक तर ट्युमर फॅक्टर्स असतात की तो ट्युमरचा साईज किती आहे, त्याप्रमाणे स्टेजेस असतात. प्लस प्रत्येक पेशंटची एक बिल्ट असते.
राईट.
खूप अगदी बारीक बांध्याच्या, सडपातळ बांध्याच्या पेशंटमध्ये आपण एक 2 सेंटीमीटरचा जरी लंप काढला तरी ते डिस्फिगरमेंट होणार. वेराज आपण बिग पेशंटमध्ये तो छोटा लंप काढला तर काहीच डिस्फिगरमेंट होणार.
बरोबर.
तर हे पेशंट फॅक्टर्स असतात, ट्युमर फॅक्टर्स असतात, मॅमोग्राफिक फॅक्टर्स असतात, एज रिलेटेड असतं, किती ग्लँड्युलर टिश्यू आहे, किती फॅटी टिश्यू आहे, असे खूप 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 फॅक्टर्स आहेत त्याच्यामध्ये. सो इट हॅज टू बी इंडिव्हिज्युअलाइज्ड.
सो जस्ट प्रोसिजर वाईज द कॉस्ट ऑफ अ मॅस्टेक्टॉमी प्लस ब्रेस्ट ऑन्कोप्लास्टिक प्रोसिजर सेम, डिफरंट?
Yeah, it is same. आपण जेव्हा ऑन्कोप्लास्टी करतो किंवा कॉन्झर्वेशन करतो तेव्हा एक सेंटिनल लिम्फ नोड बायोप्सी केली जाते. आणि आता नागपूरमध्ये फ्रोझन सेक्शनची सोय असल्यामुळे जर डायग्नोसिस डाऊटफुल असेल किंवा लिम्फ नोड स्टेटस आपल्याला माहिती नसेल तर फ्रोझन सेक्शनमध्ये आपण पाठवतो. लगेच लॅबमधून अर्ध्या तासात आपल्याला फोन येतो आणि वी कॅन डिसाईड ऑन दी फर्दर प्रोसिजर. पण कॉस्ट वाईज ॲटलिस्ट पर्सनली आय हॅव केप्ट इट द सेम.
So do you think, because you said ki 80% women still choose mastectomy, is it because presentation खूप late येतो, and do you think lumpectomy or an oncoplasty can be done in early stages?
It can definitely be done. Like anybody, I believe, कि in our own practice we have created our own guidelines through the years.
Obviously.
तर म्हणजे उगीच असं 65-70 year old पेशंटला
काहीच गरज नाही.
काही गरज नाही पेक्षा आपण वी कॅनॉट डिसाईड फॉर द पेशंट. देर आर सम लेडीज हू से दॅट इवन ॲट दॅट एज दे वॉन्ट टू कॉन्झर्व. पण मग त्यांची जर का इफ दे आर नॉट केपेबल इनफ की पुढे रेडिएशन पण लागतं, रेडिएशन बरेचदा लागतंच, किंवा समजा रिसेप्टर पॉझिटिव्ह असले, PR पॉझिटिव्ह असेल आणि ओरल याच्यावर मॅनेज करता येत असेल तर देन कॉन्झर्वेशन इज स्टील बेनिफिशियल. बट इफ देर इज अ प्रोलॉंग्ड कोर्स जो मॅस्टेक्टमी केल्यावर नाही लागणार पण कॉन्झर्वेशन केल्यावर लागेल तर इट इज बेटर टू गो फॉर मॅस्टेक्टमी. बट अल्टिमेटली आय ऑलवेज लिव्ह इट टू द पेशंट. मी इवन नातेवाईकांना सांगते की तुम्ही पण इन्फ्लुएन्स करू नका त्यांचं डिसिजन. इट इज अल्टिमेटली ओनली दॅट पर्टिक्युलर लेडी हू हॅज टू से वॉट शी वॉन्ट्स.
बरोबर. हां, ट्रू.
हां, म्हणजे नायदर हर सन or husband or daughter-in-law or
Nobody
anybody can take a decision. It is her body, she has to decide.
Exactly. But you also run outreach programs na Vidarbha about breast awareness programs. What are you seeing ki presentation late hota hai, early hota hai? Is there a taboo associated? What is happening?
Nowadays it is like people are coming early आणि somehow the disturbing trend is that young girls, म्हणजे even as young as 23 years suffering from malignancy.
They are coming with complaints of lump in breast.
Yes. किंवा असं इवन मल्टीफोकल, मल्टीसेंट्रिक हे पण खूप वाढलेलं आहे. तर युजली यंग गर्ल्स आर मोर अवेअर. ते लवकर दाखवतात. आणि इवन कॉलेज गर्ल्स, आय थिंक अवेअरनेस कॅम्पेन्स जे आहेत ते कॉलेजेसमध्ये पण होतात, सोशल मीडियावर खूप होतात. तर बरेचदा काय होतं की बिनाईन असतं पण दे आर मच मोर अवेअर अबाउट इट अँड अँक्शियस अबाउट इट. वेर ॲज ओल्डर लेडीज अरे आहे खूप वर्षांपासून मी काही लक्ष दिलं नाही. आता हे सोशल टॅबूज पण खूप आहेत. आणि खूप लेडीजचा काय त्यांचं काय असतं, आमच्या घरच्यांना काही त्रास व्हायला नको, मी आजारी पडले तर ह्यांना त्रास होईल. हे सगळ्यात इम्पॉर्टंट आहे जे प्रॉबेबली त्याला इट्स नॉट अ सिम्पल थिंग टू गेट दॅट माइंडसेट.
बट अगेन कमिंग बॅक टू हिअर की वाय डू यू थिंक early onset of breast cancer is being seen? What is happening?
Lifestyle.
एवढंच?
Yes. Lifestyle is a huge thing. म्हणजे जेनेटिक्स तर एकदम चेंज होणार नाही पण these are mutations.
My God.
Yeah.
I sometimes think the whole world needs a reset and needs to go back to old times,
Yeah, but it is not. It is going in the other direction.
So let's talk about you as a female surgeon in a very male-dominated space. You have achieved one of the highest possible things, FRCS, we have worked at the best hospitals. These are global institutes you've worked at. You have been the president of Association of Surgeons Nagpur. These are very different things you are doing, How do you see that? How do you think about yourself?
Looking back, I feel somehow nowadays there are many women surgeons in the residents and students also, girls wanting to take up surgery. So many of them come to me for advice. So I always encourage them. Talking about my own self, as I said, we just came and started out, and then gradually it developed. And I never thought of myself as a female surgeon because as I said, I started with a medical college, so there was nothing like male patient, female patient, so it started with operating everybody. And when I started my practice, I am really grateful that people used to come to me with hernias even at that stage, men. Somehow I never thought of myself as a female surgeon, or never compare myself ki I'm in a different category or anything. And actually it benefited me because women automatically developed faith in me. So it just became, like families getting connected and all. And because I never focused, I didn't want to focus on one particular area, ki I'm doing only coloproctology or something like that. My view has always been broad, that I want to do everything. I want to do good quality work in whatever I like to do. And somehow the hospitals I was working at, there was no discrimination kind of. I was one amongst the others in the surgical departments as a surgical consultant. And, that just happened. Now, there is no point in, focusing like I'm a female surgeon, or even talking about की आमच्याशी काय discrimination झालं होतं. रेसिडेन्सीमध्ये भरपूर झालं होतं. But, now that everybody has to find their own journey and their own place, and everybody's journey is different. So, there's no point in harping on that. I came to Nagpur in 2002. And I am very, very grateful to the people who were established senior surgeons, all men at that time, who encouraged me to get actively involved in the Association of Surgeons. We had this big state conference in 2003, Massicon. So I was very, very actively involved in that conference. My first, I got a big exposure that I anchored the inauguration ceremony of that event, where the likes of Dr. V.N. Shrikhande, the topmost surgeons of Maharashtra were in presence. So I was very comfortable. And when I became the first woman president of the Association of Surgeons in Nagpur in 2023, it was because I was encouraged by all these people who have been, taking up for me, backing me. I had just not expected. And very senior surgeons, I don't want to mention names because, I might lose on mentioning all the names, and I don't want to really, disappoint or hurt anybody. But they all stood by me. And they just took my name. I was suggesting somebody else's name, and Prachi, you have to be the next president. So it was a shock to me as well. And then, and a huge honor, because not coming from Nagpur, it was a huge honor to be president of the association, which I had seen, as a novice into this city. And I think my take during my tenure was different as a female. So I changed many things during my tenure. And we had a great time.
There was Massicon in Bandara, no, recently?
Gondia. Yeah.
And some surgeon had an MI.
Yeah. That was an unfortunate event.
He is okay?
No, he died.
Oh, he passed away.
Yeah.
Oh, okay. I know, let's talk about discrimination. I remember this very vividly. When I was in my internship, I was doing my surgery only.
Right.
The unit head was Dr. Vasnik, and Dr. Akhtar sir was the HOD then. And I got a lot of surgical exposure then. I was allowed to do Lord's plication and a lot of kar. And there was this brief moment where I was like, हाँ यार बहुत पसंद, खूब मजा आती है. Let's just probably do this. But then surgery, then MCH. I was like, उससे ophthalmology is an end branch.
Yeah.
It's mostly fellowship based, so that was easy. But there was this JR1 who had just joined. And she was troubled not by the doctors as much as by the patients. Catheter काढून टाकायचे. फक्त so that she could.
Oh God.
She was very troubled in her first week by the patients only.
This is really bad, very mean.
Then the boss had to come down and fire the patients. What are you doing? You pervert.
This is perversion.
It's so horrible.
Yeah.
But again, the different point is, I have worked with very amazing surgeons when I was doing my residency. Girls mostly. But very few of them made it to practice.
Okay.
Most of them went to a domestic life. Most of them, just not. Very few of them are in private practice. Why do you think that happens to such great surgeons? I feel really bad.
Yes.
Why do you think that is happening?
It is unfortunate, and it does happen. To a certain extent, every woman has to adjust and adapt. But it is up to us, I think, personally. We went through a very bad phase because our daughter was extremely premature, very low birth weight. So at that time, definitely, I had to take a back seat. And then, as I said earlier, my whole schedule depended on that. But I continued working and I continued doing everything I was doing. Only thing, my time was, arranged around hers. And now I feel very good that had I, because many of my colleagues just, they had children and then they stopped working or they just took a back seat or they just did a few hours of work and all. I think it is just your own personal decision. And I feel good that when actually there was an empty nest, I could do everything that I could do, that I ever always wanted to do. And I always feel that, we have invested so much effort into doing what we wanted to do always. Our parents have invested so much, thought and love, and they have also seen our journey, which, as a resident, there was no food and water, time to drink even water, or totally lack of sleep and everything. And I feel one must just continue what
exactly.
What one
I'll tell you this other one small story. This very good friend of mine, amazing surgeon. At the point I was thinking, kabhi mera cataract hua to tu hi karna karke. She's so flawless. Got married and the family didn't want her to work. She's like, we have enough money and you don't need to work for it. I have seen her confidence go down to a completely different person than what she was. And now I've seen her, she lives her life through calling friends. Once a week. कौन सी मशीन लिया, कोई challenging case क्या बताना. I feel very bad.
I know, it is very, not only in surgery. I mean, I have friends who had to give up because of health reasons.
So that's a different thing,
That is a different thing. But I still think that it is a mindset. Because, it is just up to you to decide, no, I'm not going to give up. Of course, a lot of support is needed from family. A huge lot of support is needed from family, and everybody has their own struggles. And there is no, you cannot compare two different people's struggles also. But, I mean, if you want to do something, I just feel that you should just continue through whatever, life throws at you. Some people find different alternative routes and then they, they are satisfied doing that also, then it is a different thing. Yeah. It's all individualized, I think.
You said you faced a lot of discrimination in your, you said everybody has their own struggle.
Everybody has that, because my time there were not so many residents.
Exactly.
Yeah.
So, but looking back, do you think they were necessary to make you the kind of surgeon you are today?
Somehow.
Some things are good evils wali.
I have always been ambitious right from childhood. I mean, as I told you, typical educated working parents.
Yeah.
Jobs. Yeah. So they want their child or their daughter to just excel in everything. So basically I was brought up to be extremely ambitious, and whatever I do, I have to be good at it. Otherwise I will not do it.
Right.
Yeah. So that kept me going. As I said, I mean, since we were discussing this, I had to stay at home when my daughter was born and through all the challenges. But the year before we were to come to India, I just took up, I called for all my surgery books, all the large volume books. Whoever came from India, I used to ask my mother to send. And then I used to read like page to page. Sabiston was a huge book, 2000 pages. Yeah. So I just started reading, and that whole year I studied and studied and studied. Whenever I used to get time, I used to sit and study theory. And then I used to remember, this case which I operated and that it was. So, that just mentally prepared me to get into it. And that is what I think, that one should just focus on what one wants to do. Then all the obstacles melt away. Discrimination in my residency, of course, there were people. I know I'm going back to that topic.
Go for it.
Yeah. But what used to be like guys, and in the residency, everybody is in their early 20s. They may be registrars or they may be junior residents. And with guys, they used to just, put their arm around each other and chalo, party, drink, ye wo, which we were completely secluded from. And I was a married resident at that. Nobody was interested in talking to me.
You're out of bounds.
I was out of bounds. I was in a different league. So that usually happened, that I was left out. Nowadays, with so many girls, I don't think people have that. But our time, it was different.
True.
Yeah. So, I did go through my challenges. But that just put me up. As I said, since school, I have been like, I have to excel in whatever I do. So that is the spirit which was inculcated in me right from the beginning. That is how it happened.
Let's talk about the other part of your life, the theatre.
Yeah.
When did you discover this side of yours?
In school itself.
Okay.
I mean, my mother's side is very much into creativity. My mother used to act even after she was working, and she had to stop working after I was born. And my mama, he has been a professional stage actor as well. In those days, he had acted with Dr. Sriram Lagu, and then because of domestic reasons, he also had to stop. But I got this opportunity again. I mean, I used to act in school. I have even got awards in school for inter-city or interstate competitions, Marathi drama at that time. And when I came to Nagpur, of course, in the initial years, I could not do that because my daughter was young, the schedules were tight. But later on, IMA, of course, is a great platform for all of us to explore our own talents. And I was encouraged by so many people, and that is how I got into it. And it comes to me naturally. So, I always, people ask me, there were a few things on some WhatsApp groups and all, how do you describe yourself? So I always say that what I enjoy is theatre, whether it may be the operating theatre or it may be the drama theatre. So it just comes naturally. Any of these theatres I am on, it's my comfort zone.
Right.
Yeah.
What was that Shikar 2016?
It was Shikar.
Shikar.
Yeah. So that was the first time I was chairperson of the drama committee for IMA. It was a thriller because, all kinds of genre are done under IMA. But somehow I am into that intense thing. So if I am the chairperson, I have been chairperson twice now, or 3 times rather.
Okay.
Every time we've gone for a different genre. And at that time, Shikar was a thriller. So we did quite a few shows of it. It was a suspense drama. And all the actors are fantastic. And we really enjoy doing that. So the rehearsals is something, which we really, really enjoy as we fine-tune our skills with our director. It was a totally different experience. Every drama we do, like the second time I was chairperson was when we did Moruchi Maushi. So that was a hilarious comedy, a very famous one. It's still running in professional theatres as well. And then the last one which we did was Sukhanta, which is a family drama.
Okay.
And that is an intense social family drama which is relevant to our times.
Right.
So, I mean, everything is a different experience. I did Natasamrat. So, I played an 80-year-old lady in that, Kaveri.
Oh.
Yeah. So, when I came, I played a 16-year-old for the first time, way back in 2006, 2007. And then to play an 80-year-old in Natasamrat. So, it's just like, it comes naturally. You get into the skin of the character and it just flows. And that feeling is something totally beautiful.
It's so intense, Natasamrat.
Yes.
How was that feeling after performing it,
Oh God, we did one show in Mumbai. So we reached, we performed in Amravati. It is a totally different experience. At that time, actually, I had just lost my mother. And I had lost my grandmother. So that role of Kaveri, in my mind, I dedicated to my mother and my grandmother. And that is how I was really able to get into it completely. I mean, Kaveri dies on stage. Yeah. So my mother passed in front of my eyes. So, I just got into that. And the tears used to stream down my eyes on their own. They used to just come. There is a very intense scene just before that, just before the character dies on stage. Mm-hmm. So, hundreds of rehearsals, hundreds of days of rehearsals we have done. But I can just emote thinking of what it was like.
How does it feel? IMA plays are mostly seen by doctors.
Yeah.
But Vasantrao Deshpande Hall, performing in Mumbai, Amravati. It's these are not your people who are watching you. It's the general public. Yeah. How does that feel?
It feels very good.
Okay.
Yeah, because we usually do one or two shows for doctors and on the IMA platform. Then we take it as an IMA production to non-doctors as well. We do this as charity events.
Right.
So some organizations who want to, have funds for, like we do for tribal girls' education. Recently, we performed for Virangula, a senior citizens group. So colleague's mother, Dr. Prashant and Nilay Nimbalkar's mother, she is into this. She is in charge of that. And we did it to commemorate 26 years of their organization. This drama Sukhanta, it is about generation gap, and it is a middle-aged couple and the generation coming after that. तर त्या वयाच्या लोकांनी इतकं ते अप्रिशिएट केलं. आय थिंक वी गॉट ओव्हरवेल्मिंग रिस्पॉन्स फ्रॉम नॉन डॉक्टर्स. या, it just depends upon the audience, how much they can relate to it. Mumbai, I did it where my teachers also, my school teachers attended this play. They could relate to it very well. Every audience is a different experience. Every city is a different experience, and we just enjoy doing that.
When I was studying here, I was never exposed to Marathi literature at all, because Nagpur madhe primary Hindi is spoken. Even all my Marathi friends, we converse in Hindi.
Yeah.
And now Hindi is also dying. I think most of people are conversing in English nowadays. I went through a CBSE school, so there was no Marathi was optional. I went for Sanskrit. And Marathi music, Marathi literature, drama, no exposure. But when I went to Pune, I could not even speak Marathi properly. So when I went for my residency, I used to call my mother Ujwa Kai Dawa Kai.
Right.
So it was so bad.
Yes.
And I told her की मला 1 to 10 मराठीत कसं लिहितात व्हॉट्सअपवर लिहून पाठव, so that prescription लिहिताना. Then when I started speaking Marathi fluently, I had a very Puneri tone.
Okay.
And then we discovered the drama in theatre. तर आम्ही पुण्यात खूप I discovered that side, and I felt sad की मराठी it is so deep.
Yes.
It is so deep. Movies, theatre, everything. So I am for the last 10 years, I'm doing a lot of नाटक आलं की आता मी बघायला जातो. We watch a movie that comes out. I really like it. Vadu was the first movie I Marathiचा बघितलेला. I still remember. Anyways, Natyotsav, you were the judge for NKP Salve.
Yeah, a few years ago.
Right. What was that?
It was a skit competition.
Right.
And I enjoyed doing that.
Okay.
I just loved it because there is so much creativity. The students write on their own, they direct themselves, they perform with props, with lights, with everything. And it just comes naturally. I don't think anybody really takes efforts to train them. And you can see the hard work. They are hugely talented college students. So just they need to channelize their energy and their skills properly.
Have you ever written or directed a play, or there is a story that you have written that?
No. I do write blogs, I write travelogues. That I have been since my school days.
Okay.
And I always have been putting it off to a later time. Okay. So I don't know when I'll do that, because sometimes I feel even I am not good at writing Marathi. Because, coming from an English medium background, my writing comes in English only. But I always feel that, I should get what I write translated into Marathi. And someday it might happen that I might write. I have lots of themes in my mind that this needs to be put down, this needs to be shared. But I think the time will come sometime when I'm really able to, put my mind to it. Because these things cannot be done casually. You have to give that much dedicated time every day. Then our temperament is different, our moods are different, there are so many other things to do which are more important. We feel that we don't get so much me time, but I'm sure it will happen sometime.
Let's do a quick thing about bariatric surgery. Do you think bariatric surgery is going down because GLP-1 medications are on the rise?
I think it is.
You think
it is affecting, because the way GLP-1 medications are being promoted world over, not just in India. In US, I have seen many people are just taking it.
It's a wave.
Or asking. It's a wave. Yeah. It's a wave. And the results are coming, but nobody knows the long-term results. Bariatric surgery also came in as something very innovative about 25 years ago, 30 years ago. the procedures have been evolving over the years. People do regain mostly because they don't follow up. They don't follow diets, they don't follow exercise regimens, and then the surgery is blamed. I have realized that many patients usually follow up for 3 to 6 months and then they disappear. And then they come back in case there is a problem. So it is very difficult. I mean, I think there are many people who are doing very good exclusive bariatric surgery work also. But statistics wise, I don't think I'm the proper person to comment on.
Oh, right. Moving on, let's talk about 25 years, more than 25 years you've been operating, saving people's life, correcting things. What has that taught you philosophically, psychologically and personally, looking back?
A lot. Right. A huge lot. I mean, it happens with all doctors, with surgeons mainly. Some patients we expect not to recover. That happened very recently with me. A patient came with gangrenous bowel. He was in septic shock. Obviously that gangrene had to come out. And what remained was just, hardly a few inches of jejunum and the colon. He was on ventilator. Elderly gentleman. I didn't think he was going to come out. Came out miraculously. And then I had just done a diversion ostomy. I just had brought out the two ends which were healthy and there was nothing in between. The abdomen was empty. He went home on colostomy bags which he was finding difficult to manage. Came back after a month. I had called him after 6 weeks, but he came back after a month. He banda karun diya. Then I realized, managing that because it was a jejunostomy. So the skin was getting dirty. It was just, acidic content spilling out of the skin and the bag also could not control it. So then I saw his general condition and I thought, okay, let me anastomose this. And he was fit otherwise. I anastomosed. Even then I was not very optimistic because there was hardly any bowel left. Of course, he lost a lot of weight. He was on the ward for about 5 weeks, but he went home. So such things are truly rewarding. Whereas sometimes you feel young patient, he's going to make quick recovery. And then you can see the patient just going downhill. For nothing major that has happened on either side. There could be just, some infection propping up. There could be anything. But moments like this, when you don't even expect a good recovery to happen and then it happens, that is the most gratifying and rewarding thing.
No money can match it.
No money can match it. And, so many times you see very poor people coming.
Yeah.
Bringing somebody from their neighborhood or their families. आपने मेरा 20 साल पहले ऑपरेशन किया था, आज मैं इनको लेके आया हूँ.
True.
So I feel those are very, very rewarding moments.
I see a different side of this, because I'm a second generation doctor. My father operated on somebody 30 years ago. And then the second and the third generation of the family is still coming to us. Yeah. That is very, very rewarding, So recently a patient who's mostly turned into a very close family associate. Now they had a granddaughter.
Okay.
And my father was called for Kirkum Ghariya. So that's the fourth generation of the family now. And I think of it as a very big responsibility. I have to make sure this trust is not broken.
Absolutely.
It's very important.
Yes.
Do you remember one patient where it was like, I don't know what is going to happen, but it turned out really good, other than this, what you told. And yet you have had good relations later on.
There are many patients like that. Going back to my residency days, there was one patient who had taken some corrosive substance, suicidal. He is not there anymore now. He died. But, treating him at that time, we used to take so much effort. And as you know, as residents, we are completely in the ward and we are emotionally so connected with patients like that. So, that really, during my training years, that really, made me think a lot. Why did this person do this? Why did this young person? And then I did a few corrosive injuries later on also. So, whenever a patient comes with corrosive injuries, and later on most of them and all of them are doing well. So there is another young person, so I had operated on him about maybe 15 years ago. So now when he comes, a full-grown man and has a family and all that, you really feel good about it.
As a surgeon, what do you know about the human body that a lot of people don't know about their own bodies?
Mostly all doctors know much more about the patient's
Obviously.
body. I think, everybody, we all, including us, we take our bodies for granted.
Right.
Most of the things.
Yes.
And we abuse our bodies. I mean, I'm
Absolutely.
using the term we because we are no different from any of the patients. So I think we must be just, very grateful, and we should treat our own bodies with care, with what nature has given us, and do
Nice.
everything possible to preserve it.
So, one rapid fire round, then I'll let you go.
Yeah.
Okay. First surgery you ever performed solo, which was it?
In my residency days, must be a hydrocele.
Hydrocele.
Yeah.
I think.
Yeah.
Hernia hydrocele.
Yeah.
Most overrated thing in modern surgery today?
Most overrated. I think people have become very technology dependent now. So I think it was overrated and basic skills have been ignored.
One food everyone should stop eating.
I wouldn't say there is anything which anybody should stop eating. I rather tell patients you just continue to have what you were eating, because there are people who suddenly go on a diet plan and then they say gently, they'll come out with it gently. They come with gastritis or even pancreatitis or some fissure or hemorrhoids. And then gently after prodding they'll say nahi humne wo last week se ek diet plan chalu kiya tha. So usually I don't tell anybody to stop eating unless there is of course severe diabetes, and obviously we have to tell patients to stop eating sugar.
What is the hardest conversation you have with your patients?
Breaking the news of cancer.
Again, general surgeon or a super specialist?
General surgeon.
General surgeon. Nagpur or Mumbai? Honestly.
Karma Bhumi, Nagpur. So Nagpur has given me what I am as a surgeon.
Okay. Honestly, I don't like Mumbai at all. It is highly crowded. It is dirty and in chikat. I can't tolerate humidity. So this is better. I would rather do 48, 49 temperatures rather than chikat.
No, for me. Yeah, sorry, you go on with the
One
question.
book every doctor should read that is not a medical textbook.
That is not a medical textbook.
Yeah.
I have read The Alchemist many times.
Oh yes,
Yeah.
it's a very nice book. The worst part of the job that nobody talks about.
The hard work.
If not a doctor, would you do theatre?
I would. I would do many things. I would become a pilot.
Really? Oh.
I always wanted to do something different. So at that time, of course, I mean, being a pilot was something different that time.
Are you still passionate about being a pilot?
I am. I have a few passionate friends, so we just talk about it. We don't do
Why
anything.
don't you get a CPL license?
Let's see. I think I've crossed the age bar also.
Oh, okay. I did not know that.
Yeah, there
ठीक
is
है.
an age bar.
Chalo, if you could tell one message to every female watching this about her health, what would you tell them?
Take care of yourself first.
Okay. And for a young person, doesn't matter, boy or a girl, who is wanting to take up surgery, what would you tell them?
If you want to do surgery, just do it. Don't think about कैसे होगा, क्या होगा, लोग क्या कहेंगे. No. If you want to do it, just do it.
How do you prep yourself before surgery?
As we discussed before, it is on auto mode. But I do think I chalk out plans, anticipate what can happen.
What are you building next? Hospital Banla, you have had a theatre presence. What are you building next?
I am just doing whatever I am doing better. I am doing a robotic surgery fellowship right now. I don't have access to a robot in private practice, but since it is going to be the future, I must be equipped with the skills.
So where are you doing this?
GMC Nagpur.
They have robot?
Yeah, it is an MUHS fellowship. They are doing excellent robotic surgical work.
Da Vinci, this is the only one.
No, that is the Mantra robot.
Okay.
It is an Indian robotic system.
I know Da Vinci because the सगळीकडे ad त्यांचे लागले
Yeah,
असतात.
exactly. Yeah.
Otherwise, I have no use to know this. Thank you so much for being here.
Thank you so much for
any
having
closing
me.
thoughts, please?
It's excellent to go back and reflect on my own journey. And I think you have succeeded in bringing out many sides of me philosophical and the professional and the practical and everything. So I think it is important because normally we don't reflect on our journey. And it is a good, venting mechanism and a reflecting mechanism to do this. So thank you so much.
Thank you for being here.